Hi, I'm Dr. Jim Hermiller from St. Vincent in Indianapolis, Indiana. We're so fortunate to have Dr. Patrick McCarthy here with us, who's Chief of Cardiovascular Surgery at Northwestern and needs no introduction. And we're here right now at the Heart Team Summit that's being held, and it's been really an exciting meeting.
It's been fantastic.
Yeah.
For the first time out of the box, we're doing great.
Yeah, 3 institutions, we brought it all together, and we've had great discussions. One of the discussions has been around mitral valve and where we're headed, and we're going to talk a little bit about transcatheter therapy, and I'd love to have your kind of thoughts on where we are right now. What's the landscape? Where do you think we are today? And then we'll get into where we are going to be tomorrow.
So first, Jim, I want to point out for the audience that you and I are about to debate this, and I think that you're really just trying to do this so that you hear all of my tips so that you're prepared for it before we go ahead with this. So I'll have to pick your brain too. So first of all, transcatheter mitral is not transcatheter aortic valve therapy. It's been around for quite a while. We've been trying the aortic valve. I've heard Marty Leon described as a stupid valve. Yeah. This one is like a neurotic, complicated, difficult to handle valve. There's a lot of tricks and nuances to it. So the transcatheter mitral replacement, theoretically, I thought was a great idea. In practicality, that LV outflow tract obstruction, the calcium on the mitral annulus, and things, it's been an impediment to putting patients into the trials. MitraClip, of course, has been the big sort of standout success. There have been 100,000 implants so far, and I know you've put in about 50,000 of those, but you know, it's coming along kind of slowly, and at least in the U.S. right now, it's only approved for that very high risk or inoperable patient group, and soon we'll be using it for functional MR more. So, but we still have a long way to go with a mitral. Yeah,
part of it is the bar for mitral valve repair is so high.
Yes, so that's going to be in my talk. So the issue, especially with degenerative mitral regurgitation, is that I've been entering patients into the STS database who are like a typical 60-year-old pretty healthy patient. It spits out their predicted operative mortality is 0.2. It's about like an appendectomy or a tonsillectomy now. It's just so low. And then the results of the repairs these days are very high, very durable. And so it really is, it's going to be a difficult bar for transcatheter therapies to approach that.
You know, as we look at trying to get into potentially maybe an intermediate risk group, particularly the elderly, maybe at 85, you know, a transcatheter may have a room, but they're not really prohibitive risk. I know you're involved in a study that may be, you know, get into that population.
So just like TAVR progressed from partner 1 to partner 2. Sable Carr and I are the principal investigators. You're going to be one of our investigators on the steering committee for a trial called Repair MR. It was just approved by the FDA. It was actually approved faster than we expected. We submitted all the paperwork, expected the usual amount of questions back. They had 0 questions. They just accepted it. And so it is for patients with degenerative mitral regurg, 75 and older. If it is a clippable valve, it has to be clippable. If it's clippable, it's repairable. And then 65 to 74 if they have comorbidities, like a predicted risk of mortality at 2%. So anybody 75 and then kind of a sicker population below that, but not your kind of 50-year-old patient either.
Let's talk one second about secondary MR, and then we'll kind of get into the future of degenerative. So where do you think we are with COAPT, Mitra FR? Where do you think we are today with MitraClip and secondary MR? What's your impression?
Well, if you look at that all that population of heart failure, there's definitely a sliver of them that are going to have severe MR, and their ventricles are abnormal, but they're not horrible. They're not 20% EF and 7-centimeter ventricle. There's going to be that group of patients that if you clip them and you get rid of that MR, the patients are going to feel better. That's what COAPT is showing, and then surprisingly also their survival was better. So what we don't know is that group of patients like a thin little sliver, or is it actually pretty wide? And so Mitra FR would indicate, well, there's boundaries. If the ventricle is really bad, then, or if the MR isn't all that bad, that they may not respond very well. So it's going to be a real active area for us to try to explore in the next several years to figure out who are those patients.
Okay. Let's kind of move on to the future of transcatheter therapy, of the innumerable. You know, it's a giant number of these therapies. Which one excites you the most?
Well, I think the leaflet therapy definitely has legs. I mean, if, you know, just we know from the Alfieri repair, I've been doing it since about 1996, and I still do it in about 7% of my mitral repairs. And so we know that in the right patient, now for me it's combined with a ring, but we know in the right patient that it is very good and durable repair. And one thing about the transcatheter is it's very safe. You know, you just go up through the femoral vein and across, and so safety has been excellent, and durability has actually been pretty good. And so part of that repair MR trial is going to be to rely on the interventionalist or the surgeon's judgment about, is this a clippable valve at a success rate of like 85%? If they think they can only get it down from 4+ to 2 to 3+, that may not be such a good outcome for that group of patients. But I think that the clip therapies are good. I think the annular solutions look really interesting. In general, they've been a little difficult to do, transcatheter. We know for functional MR, I sew a small ring on, and, you know, under direct visualization, I get it right there, and yet still some of them leak because the ventricles are dilated. So that won't be for everybody, but it'll be maybe a combination of a clip and then an annular solution in patients is going to be a good solution. And then transcatheter mitral replacement, it feels like we're still kind of early in the iterations of the technology, and maybe we're going to figure out things like what we saw earlier today, which was the lampoon procedure to split that anterior leaflet right down the middle. That's like a real surgeon's approach for interventional. But and when you do that, that may be the way that we really avoid outflow tract obstruction more often. So we'll learn a lot more about that one.
It seems to me one of the predicates, if we're going to get down into low risk with transcatheter in these degenerative patients, you can't lock out a surgical repair option.
I think that's a great point. I think that in particular was why when we were designing repair MR, I said, okay, an 80-year-old, I have equipoise about replacing the valve versus a repair, and because having a failed repair in an 80-year-old a year or two later, that's a real problem. But to do something to the valve that will preclude a repair in a 50-year-old, that's got to be something you really need to think that through. That's going to be a problem for some of them.
Well, great. Any final thoughts?
No, I think that this last decade was just incredible, the amount of change we saw in TAVR. I mean, it just revolutionized our field. This next decade, I think, is going to be about mitral and tricuspid. And I think that it's not going to be as simple as just put that balloon in there and then blow it up or just release it. This is going to be more complex.